I love listen only mode.
Hi, everyone. Welcome to another VITA Learning webinar. Today we've got Mr. Marc Wagenseil, Denturist extraordinaire, the Wagenseil Weagle master of our company. So Marc is going to teach us and train us and help us understand a little bit more about the combination syndrome, about the what happens when we have a case that is opposing natural dentition. How do we look at it? How do we treatment plan it? How do we fix it? How do we make it work long term? So before we get into the webinar today, there's just a couple of reminders. One is that when you have registered and your box is up to go to webinar, there is a box on your far right, a panel. And since everyone is going to be on mute, you will need to write in your questions through that question box in that panel and then send them. And then at the end of the program, we'll do some Q&A. So please, during the meeting, if you hear something, Marc makes a comment, says something that you love or that you hate, please write in a question and send that to us. And we'll rattle Marc's cage a little and ask him some of them very poignant questions, put him on the spot. So Marc is going to join us from Canada. He's still residing in Canada. They won't let him out of Canada yet into the United States. We were just talking about that. Also, we are going to record this webinar. So if you want to revisit it and review it, go ahead and join us on our VITA North America websites, the YouTube channel. We have an North America VITA North America YouTube channel that we have all of these recorded webinars. Marc's probably done about 8 of them so far this year. We've got probably as many more to go the rest of this year or so. But you can check out all of the other webinars and videos that Marc has graciously joined us with on this under the VITA Learning webinar umbrella. So please visit us. And we are going to start this program. So Marc Wagenseil is a denturist. So he's going to give us a perspective from not a technician's point of view, but from a denturist point of view. So it's really great because he can communicate, give you information if you are a technician or a dentist or another denturist, but especially technicians. Since we don't see a lot of the actual clinical work, we just get case pans with white rims and bite blocks in them. Marc will be able to help you understand what really you should be asking for the dentist from them to give you the right information to do the case and the patient justice. So Marc will kind of go back and forth from the perspective of interoral use, almost like from a dentist, but as a denturist. So Marc is a global certified trainer for VITA and a consultant for us. He's a licensed denturist and dental technician with over 30 years of experience. He owns his own dental lab in Edmonton, Alberta, Canada. And he's spent his career focusing on how dentures integrate into the mouth and body and inspires a unique awareness of occlusion and professional growth. So, Marc, welcome. We have a whole webinar. This will probably run about 45 to 60 minutes in the Q&A. So we'll it's a very lively discussion at the end with the Q&A. So again, everyone, if you have any questions, please submit those questions, and we will go ahead and address those at the end of the office. So I'm going to turn this over to Marc, and I am going to let's see here if I can make this work. You are now the presenter, Marc. And I am going to leave the screen. There you go.
Okie dokie.
And it is all yours, Marc.
Awesome. One moment, please, while we get ourselves organized. Jim, I'm going to check in with you just to make sure that everything is working and you can see things.
Yep, it's being pulled up now. I can see your hand before you put it in. I can see your upside down face.
Yeah.
So you are good to go.
Awesome.
There you are.
Focusing.
Excellent.
Right.
It's a perfect mugshot.
Cool. Yeah, thank you. How did you know? All right. Good morning, everybody. Woohoo! Welcome. Hey, thanks for coming. Thanks for investing in yourself and in growth and the growth of our professions. As denturists or dentists or dental technicians, we are pushing forward to grow our professions and to be more. And we're trying to be a superhero to that patient. They trust us, whether they have direct contact with us or not. They want us to be their superhero. So let's try to do that. They put a lot of faith in us. So number one, we don't slap teeth together. Woot woot. We do not slap teeth together. Far from it. So thanks for joining me. Let's get right to it. This is a fun one and a fun topic. We don't discuss this often. Single upper dentures to natural lower dentition. And boy, can they be difficult. And they cause us a great deal of stress over the years. So woof, I've learned a lot and have really changed how I've presented myself on upper dentures. So bear with me. I'm going to talk about a lot of pieces that influence this. So as we go, I'll tie them together. So thank you for your patience on that. I'm going to flip over and we're going to come down to this page here. Typically what we have is we have a lower dentition. And typically what we are taught to do from school is you take that denture tooth and you make it fit. And you grind it into place and you make it fit against this contour of the lower. So denture teeth come to us on already made, and they come to us and typically they're congruent and symmetrical in terms of their shape. And now we're asking to fit against something that is anything but. So what do we typically do is we grind, and we fit that tooth and we make it fit snug. And you want it to fit snug on there. So we let the lower dictate how the upper is going to fit against it. And I started to challenge myself to say, why are we doing this? We actually need to pay some attention to what the upper is doing and not just let the lower shape solely dictate what we do and why we do it. And so it's difficult because we also have the case scenarios where, say, the lower is shaped like this. And now all of a sudden, you have lower teeth that are shaped this way. And now the upper teeth are coming in and we grind them in this way. And it's a negative curve. And all of a sudden now we're dealing with a negative curve and we say, well, we can't do anything about it. So we set the teeth like this because we're supposed to set them and make them contact and have. And all of a sudden now the denture's breaking, there's cracks, teeth are chipping, patient can't chew, and it's loose and loose and loose. And we reline it. And then you get that work order from the doctor that says, this is the second time we've relined it in 6 months. And then they do this and draw you a little sad emoji on it because, you know, everyone is sad. And so these are questions and situations that follow us and dog us. So what we're going to do today is we're going to peel this back. I have lots of different kinds of models. There's lots of different kinds of situations that we're presented with. And I'm going to talk you through how I approach it, how I have approached it, and how I've been able to eliminate some of the stresses that we're plagued with. I need to give you some background information on that before we get started, so bear with me. It's been an issue for us. So 1 minute while I do this. Whoa. And I come back here. And it's been an issue for me because what are our common single denture issues that we deal with? Well, number one, denture teeth chip, break, and pop off. That's common on a single denture, whether it's implant retained or not, and whether it's going to be digitally done or not. Patient can't chew well with the new denture. They often get complaints on that the old denture fit better than the new one, and they just can't seem to mince the food or chew the food. We get that a lot. It just doesn't work in their opinion. and the new denture is looser than the old one. Multiple relines with no success, corset breaking, and food collects under the denture, but no reline warranted. The denture cracking one is a big one because, of course, we reinforce it. We're using fiber force or metal pallet, and then things still break and still chip, and we still have problems. And so I honestly banged my head against the wall for the first 15 years or so of my career, wondering, what am I missing? I mean, school taught me how to make the upper denture. As I said, you fit the lower teeth against, you fit the upper teeth against the bottom, and you grind it in and you make it contact. But there wasn't a lot of discussion, and there was no discussion about how this is really going to function in the mouth. We were trying to get working and balancing occlusion, of course, on the lower dentition, and that's all they taught us. I'll always remember this, about 6 months into owning my office. So I was fresh graduated from school and licensed and set up my own office. And I remember I made a complete upper denture, and the patient came back at about month 4 or 5 and it had cracked. And so what did school teach me? Oh, I'll fix that for you, sir. No, you're going to make me a new one. What do you mean? Oh, this is only 3 or 4 months old. You're not fixing it. You're making me a new one. And so it's funny because school didn't teach me how to deal with that situation. And now here I am, fresh young grad, licensed, and someone's demanding that I redo the denture because a repair isn't good enough. And so I didn't understand why things were breaking. And certainly we could say it's torque now or things, but my bite was right, my centric was right. Why is this thing breaking? So this was a frustrating thing for me, and it was difficult to work through that. And I've learned certainly the art of diplomacy now with dealing with patients. The other big situation that we feel is, that we deal with, is that the new dentures are too big, because you have to watch how much you change the vertical on a patient compared to what they had. And of course, soreness. Typically what we see with upper dentures is they come to us very well worn. Sometimes they've worn right through the dentition and right into the pink of the denture base. And these things are very well worn in. When they're well worn in like that, there's a pattern on that denture. There's a chew pattern now ground into that denture from their lower natural teeth and their chew pattern. And then we're going to go in on a new denture and change it. And then, of course, as a doctor, they're trained to open the vertical and put it back to where it should be. So there are some things that are beyond our control as a dental technician. Number one is the impression. Number two, of course, is the vertical. So these are things that we can control, but what we can in the lab is, especially if we have an understanding of what the denture is replacing and the condition of what the denture is replacing, we can do some things in the lab to make it easier. And as a denturist, it's the same thing now for me in the lab about how to deal with it. So thank you. I will now peel the layers back. So these common issues cause us a great deal of stress over the years dealing with upper dentures, and especially now on implant retained dentures. It's frustrating. And of course, the patient has spent money on this and they're frustrated. And it's difficult conversations and critical conversations that are being had because things are breaking and not working right. And of course, like any consumer, they don't expect something to break within 3 to 6 months of having it purchased and put in their mouth. I want to talk to you about freedom and centric. That's a flat area in the central fossa upon which opposing cusps contact and permits a degree of freedom and eccentric movements uninfluenced by tooth inclines. So that's something that exists for us naturally. So what is that? Is a real life example. When we touch our natural teeth together, and if I ask you to gently hold them into centric in now, and if you gently hold, sorry, I can't talk and turn the camera on at the same time. If you hold them into centric, whoops, let's try that again. See, Canada's upside down. There we go. So if you hold your teeth into centric, now just wiggle them side to side in centric. So don't centric. You can. There's just this ever bit of slight. Now, over the years and through all the courses I've taught globally, I've met only a handful of people that have had issues with this. Most natural dentition has some degree of a little bit of wiggle, and that wiggle, everyone, is freedom. So yeah, you got a little bit of wiggle in your bite naturally. Why? Because this temporal mandibular joint isn't locked together. It also has a little bit of freedom in it, and there's a little bit of wiggle. So as Jim alluded to, this is the Wagenseil wiggle, and this is freedom, and freedom is good. Everyone, freedom is good. We don't slap teeth together. Freedom is good. So what we do is we build an upper denture, and we build it to lower natural dentition, and we lock it in. And we're taking the teeth and we're making them fit against the lower naturals because that's what we were taught to do. And we inevitably lock it into position, which is absolutely incorrect. And I'm going to teach you how to change that and how to not do that. But on more with the pie. So with that said, that's freedom and centric. And that's the real life example. Why is that important? Why do we have wiggle? And why should we use denture teeth that have wiggle? So for upper and lower dentures, this is important. And now spinning it over to natural dentition, this is important. Because what happens is we need a degree of freedom. So on the left screen, there needs to be that little bit of wiggle room. And that wiggle room is usually controlled by the lower. So in complete dentures, it's the lower that has, as I call the bowl, that has a little bit of flexibility. So the upper cusp sits in the bowl and it has that degree of freedom. The freedom is built into the lower fossa or into the lower dentition or the lower tooth. When we flip that to a single denture, we're going to have to put that into the upper teeth. But what we're getting at is that we don't want to, now on the right screen, hit and slide into position. So if you lock your bite in and the patient's chewing and it hits on the guiding planes of the tooth that you see with the arrows and it slides into position, that causes the rock. That causes it being loose. Now remember, think of natural dentition. It's worn down sometimes. And then the denture that's being replaced is well worn in. So the patient has actually worn in the bite. They've worn in their own freedom. And now we replace it with a new denture and we take that freedom away, thinking that we're helping them, and we're not. And this is what's causing the problems. Remember, you are asking a patient to bullseye centric every time. You know that's impossible, correct? You're asking them to be accurate within how many tenth of a millimeter. If the bite's locked in, it has to be perfect. And now you're asking them to do that. And now you're asking, most cases, a senior citizen to lock in to centric. And now remember, there's no nerve to the denture teeth. There's no nerve into that. So how can they tell? And we want to make sure that we get rid of the hit and slide, because the hit and slide causes the problem. So now I'm going to show you how to deal with that on an upper basis. But I wanted to, again, set the tone to say what's freedom. This is what it looks like. It has that degree of freedom. So now even this is an upper and lower case where you see now we're doing typical working and balancing occlusion, but now that's that freedom in centric where I can rock it slightly in centric and it has that little bit of 1 to 2 millimeters of play. We're going to search for that on lower natural dentition so that we can copy that into the upper denture. Because again, you cannot expect someone to accurately reproduce their bite every time under every situation. Why? Well, let's talk about the chew cycle, because this influences it. So again, for those that are joining me again, you've seen this video. It's a fantastic video. This is people chewing real life. So this is natural dentition, but I want to prove my point. Number one, the jaw does not track straight up and down. Can you see how it comes in at an angle? So now we're going to have to take upper denture teeth and match them to lower natural dentition, yet following within that chew cycle. And you can see, look at the arc of closure. Now look at the upper teeth. Do you see food stuck to them, clinging? And look on the right-hand side. You see how it's getting chewed? And the upper cusps, so the upper buccal cusps are there to help shear the food and hold the food on to the lower dentition. The lower is holding the food and bringing it up to the uppers to get crushed. So this is important. The lower holds the food, the lower brings it to the upper teeth, and the upper teeth crush the food. The patient has a unique chew cycle, so you can can actually even see the freedom on this one. It's so crisp and accurate. There's that, they touch and they actually slide and then they open again. They have that freedom, that little bit of wiggle room. This is awesome. Now let's look at this. This is again, check the chew cycle on this patient. You see how it's more vertical? The other ones you saw were a little bit more horizontal. This one's a little more vertical. And you can see that now with the angulation of the premolars, or the first and second bicuspids, they're quite angled. So the point in this video is to show you that everyone has a unique chew cycle. It's as unique as your fingerprint or your retina scan. And when they chew, the lower holds the food, brings it up to the upper. But there's food also clinging to the upper teeth. So what's important here to remember is you can't have knuckle tight occlusion. If it's knuckle tight, it squishes the food off. The food needs to stay on there to get chewed. When we build a super tight denture, the food's always getting pushed off. There's no way to get it crushed. Everyone has a chew cycle. And so now I've sort of simplified it by showing you some are flat, some are oval, some are more oval circular, some are teardrop. The trick is when you're a denturist or a doctor, you can see this. You can actually identify the chew cycle of a patient. If you're a dental technician, you can't because you don't see the patient. So I want you to understand that there's a chew cycle associated with that person. They chew in a certain way, like we walk in a way, talk in a way, act in a way, you chew in a certain way. And Articulator doesn't mimic every motion that's available there. So number one is to try and understand what denture are we trying to replace. So what is the current condition of the denture? If you know if it's very well worn in, then you know that there's a certain bite pattern there, and you can usually try to identify whether they're sliding to one side or not, and then you can make that correction in the lab as you move forward, because you're going to be changing this with a new denture. I want to show you this video. So this is someone speaking. Now to identify a chew cycle, I have the patient speak days of the week, months of the year, English and their mother language. It's going to show me how the jaw is moving. So this is scene 66. Watch. Can you see the movement of the jaw? Posture's out to the left a little bit. I need to clear more room on her left. See it move? Now remember, she can't feel anything with the denture teeth. They're dead. There's no way that the brain can understand the three-dimensional positioning of these teeth. Yet they come into your office and they're either chipping, breaking, or they say that they're loose when they talk. That means that the teeth are moving and they're hitting against each other, but they can't feel the hit because there's no nerve to them. Other patients saying days of the week. This is a great case. So watch this one. You see the movement? See it swing to her left? Look at that. Do you see that? Oh, let me show it again. Okay, so all the dental technicians in the house, woot, woot. All the dental technicians in the house. Okay, if you have cases that are driving you nuts and they're coming back all the time, this is what you need to find out. The doctor needs to take a video of the patient saying the days of the week and the months of the year in English and their mother language if they have one. Then you need to see it. And then you're going to see that jaw track, because you see how it tracked to the left? So I had to clear out all the denturists in the house. Woot, woot. Same thing now. Have the patient now clinically when you're doing a wax try-in or during your consult or such, have the patient say days of the week, months of the year, and you're watching this. Because this is a complete denture case, but here's the point. Look how I built it. Look what I did with the overbite, you guys. There's like 5 millimeters of overbite on this case. Oh yeah, that functions in the mouth right now. I broke every rule of what school told me is possible. Oh, you're supposed to have an overbite of 1 to 1 or 2 to 2. Look what I did here. It's like 5, 6 millimeters in there. Look at this thing. And this functions, and she can function and eat with this and not use adhesive with this. Why? Because I identified this, I identified her bite, I identified her chew cycle, I vented it and cleared it out where it needed it by the yellow arrows because she swings out to the left, and I identified these things. And now I can build that for her. And I challenged myself. You guys, how many dentures do you see and think that that's going to function in the mouth? It functions and it works. And it's in the mouth now. And it taught me that I can change and bend the rules when I understand it's a chew cycle and I need to give them freedom. Because freedom is good. And this is going to apply to upper denture as well. Now what I did was, this is another case, but I've identified and blacked out the lower anterior teeth to prove the point. Watch her jaw. You see it move? So that's what you're trying to identify. So again, what does the patient want? Well, they don't want any of the things breaking, chipping, relines, and all of this business. They don't want that. And we don't want that either because it causes us stress. That's what they don't want. So again, I'm going to switch out. Bear with me as I jump to the camera. I wanted to show you those things because that's going to influence now as we move forward why I do what I do. I've identified, number one, that someone has freedom. Their bite's not locked in. Number two, I've identified that I have to follow their chew cycle. Whether I can identify it myself or not, I know that one exists. Okay? So bear with me while we get this in. So I have an articulator. I use a Protar. So this is from Cavo. You can also use a Stratus. So a Stratus 300 does this, or a Protar. And what the articulator does is it does this. So that simulates freedom and centric. That's the wiggle. Okay, there's your Wagenseil wiggle in an articulator. Okay, so I wiggle. Now this articulator also does articulator, but it also does this. So it does a straight horizontal move, which is again, much like we see in our natural dentition. So I'm going to swing right down and I'm going to focus. So I have about 4 different lower models of situations here. So let's start to piece this one apart now, and we'll start here. So we'll look at the lower molar. So what's important now is you can start to identify. I take a look at the tooth. And now, where's the deepest part? Well, right there. So where am I going to put my upper cusp? Well, right there. Because remember, I said you have the lower, and I'm looking for that fossa, the deepest part, to pop the tooth in. Okay? And then the upper, I'm going to look to put that corresponding fossa, corresponding cusp into there, and start then grinding it in from there. Okay? Now, what's important is that I'm going to then take that upper cusp and I'm going to thin it down to create my freedom here so it's not locked together. So again, typically what we would do was we would take the tooth. So here's the lower, like that. And then I would put the upper denture tooth and grind that sucker in so that she's tight. No. We're going to take it, there's the lower, and now I'm going to go in, but I'm going to permit that degree of freedom. So I've got my centric contact, but now I've got my freedom. And then I'm making sure that I have that green, which is my freedom in there. So I'm going to have to do a little bit of sculpting, but I'm doing it cautiously and carefully. That's our goal here when dealing with upper dentition. Okay? So we're going to come back in, refocus, and again, forgive me because I've got the camera nestled right up. So I'm going to be shooting in here. And then what happens is when I tip it, you can see I've got the guiding planes that I can get the working and balancing from. And then I'm going to just grind the cusp so that we get that degree of freedom in here. So I'm looking at each natural tooth, specifically and then I'm grinding in that tooth. So here, I'm going to be shooting for that cusp right there. I'm going to put it into that position. I'm going to be shooting for here. Now look on this side, different situation, okay? Different contour. So I'm going to be shooting right in that area to put that cusp, okay? And I have to custom in there. Now this one, awesome. Look at this. So again, that lingual cusp right into that area in here. This one's a little easier to define right in there. So regardless of the situation, I'm taking a look at the teeth, and this is how I do at work, is I mark it with a pencil. So I've got one of those little clicky pencils, and so then I can go in here and I can go, this is where I want to place the initial cusp. So it's not just put it in and start grinding like crazy. It's what's my target? What am I trying to accomplish? And then move forward. So we're going to grind it in. So I'm going to grab a tooth. So let's pick one here that's a good size. So I'm taking a VITA lingual form. Okay, it's a 24L, so it's quite a large tooth. So again, this is for dentures, but now I'm going to incorporate this into a single denture case. And what I'm going to be doing is I'm going to take that, remember, I'm going to take that cusp and I'm going to be shooting for that position. So what does that mean? I'm going to be taking the cusp and I want this lingual cusp right here. So that cusp will go into that black dot fossa. Yes, I just dropped it. Okay. So it's going to nestle in, okay, like this. Okay, like that. Now, if I wanted to, I can also come forward, depending on the situation. Then I'm putting the lingual cusp into that position. So I have some flexibility here, but the goal would be to try and get the bigger of the cusp, which is that buccolingual in there. And that's what it's going to be doing. And I'm going to be nestling it in there and then grinding it into position from there. Okay. So this time I get to do hands-on work. So bear with me while I heat some wax. And we're going to tap this in and I'm going to show you how I do this. Lab-wise. Okay. So my initial comment was I'm shooting for that cusp into that fossa. So how do I check that now? So normally we would pull out articulating paper. I am going to take my pen. So this is a Statler Lumicolor non-permanent pen made in Germany. Okay, cusp. Now, why am I paying attention to cusp? Well, here's the deal. Here's the lower, okay? The lower is the bowl. It holds the food to bring it up to the upper teeth to get crushed. So the lower holds the food and it brings it against the lingual, usually the lingual distal, the lingual mesial cusp because it's the largest, and the food gets brought up and it gets crushed against that. That's typically how this works. And then there's a chew cycle involved, which means there's some type of a chew cycle, okay, whether it be more horizontal or whether more vertical, that this works in. Everything is mathematically equated to each other in that patient. Everything works. So with natural dentition, sometimes now it gets a lot flatter. So now I have this type of point. So now I have to take this cusp and grind it down and get it to fit how I need it to fit. That's what we're doing here. And then I'm watching the guiding planes here to keep my freedom, so I keep my wiggle room. Now I can do that with VITA teeth because they're made from acrylic glass. And I don't have to polish them after when I grind them because they're self-polishing teeth because they're acrylic glass. And acrylic glass against natural dentition is good. It's not as hard as natural dentition, but it works. It's harder than typical IPN acrylic. So what I'm able to do is to grind the tooth without damaging it. There's no layers to it. It's homogeneous all the way through. So what I've done is I've taken the upper distolingual cusp, I've coated it in red, and now I've aimed for that little black dot, and now I can find my centric. And what's it doing is it's going to start marking red within that fossa. And you can just see it. It's red, red. So I'm not using articulating paper. Why not? Because articulating paper bends. So when I have this situation and I use articulating paper, regardless of its thickness, when I place that between the teeth and the patient chews, the paper's getting crunched and crinkled between the cusps. And I can get a wrong reading because it's getting crunched and crinkled. I don't want crunch and crinkle. I want an accurate of where this thing is hitting and to what position it's hitting. So that's why I don't use articulating paper. I use the pen. And Marc, Stapler, Lumicolor, non-permanent. Stapler. Okay, or you can use a Sharpie. Just make sure it's non-permanent. This one again, made in Germany. Okay, Stapler, Lumicolor, non-permanent. So what I'm doing is I'm taking this, coloring it, tapping it in. So now even let me take the pen out of here. Tapping it in to find centric. Now I'm going up and I'm looking to see, you can see where the marks are. See, it's marking in red there for me. I've marked black, so I know where I was shooting for. And now I can take this and I can grind it. The beauty of this is you can actually see right there. Let's see if we can get a super, let me stop shaking and bring the camera down. You can actually see there's a mark right there where the actual ink gets marked away by the model. It's that accurate, everyone. And so it teaches me where to go. So now I can take this and I can grind it. So forgive me while I make noise. And I'm grinding that cusp down. You're saying, Marc, what are you using to grind it? A diamond, something really fine. Okay, so a diamond burr, really fine, please. Okay, so it's not leaving it rough. Because remember, this will self-polish. And then again, I go in and I color it again. And then I come in and I tap it into position. And now again, I look for the marks. And you can see how I'm going in now and I'm putting it in. And now what I'm going to do is I'm going to go in. So just let me adjust the camera again. And now I'm going to open my articulator. Now, typically what we do, everyone, let me just zoom right in for you so you can see this. Typically now we would do the standard working and balancing occlusion. But what I want to do now is, remember the wiggle? I want to do the wiggle in there. You can see how it's already rocking the tooth. So I want to do the wiggle. So what that tells me is that the tooth is rocking against the inclined planes. So remember how I've identified the inclined planes? You can see where it's already hitting. So it's showing me where it's even hitting on those guiding planes. And if you look on the tooth itself, look at that. Look, can you see it? it's hitting on the guiding plane. That's the cusp tip is right up here, and it's hitting on the guiding plane. I need to grind that guiding plane right there. So let me do that. Come back, do a recolor. Come back, and I do the wiggle. Now I've rocked the tooth loose, so I'm gonna have to reseal it. And I do the wiggle in there. And what I'm doing now is I'm facilitating that wiggle. I'm facilitating freedom and centric, because remember, a patient cannot accurately touch together in the same position every time. So now I'm grinding the tooth and the cusps to facilitate that wiggle and that freedom and centric. And that's how I do it. It doesn't change whether it's an upper denture. It doesn't change if it's an implant denture. It doesn't change if it's digital. Digital is a little different in just terms of I might have to do that more manually afterwards because there's some limitations to how we can do that digitally. But that's what I'm checking for. So not only am I just solely looking at that, working and balancing, but I want that wiggle. I need to facilitate that wiggle, and I need to find that and then grind that against the cusp. The other thing I want to talk about in that motion of doing this is we have the lower and we have the upper that sits in it. Okay. So now I'm showing you how I'm keeping my centric, but I'm grinding the guiding planes of that tooth into that fossa. I always want this overhang though, if we can at all possible have it. Remember in the chewing video of the patients chewing the cucumber and the carrots, this is a shear cusp. It helps hold the food. Look how the shape is that it comes over. It's there to help hold the food onto the food table to get crushed. We want some overlap. I don't want that too shallow if I can help it, because then the food comes off right away. I want to maintain this to have the food try to get back on. Remember how the food was sticking up here on the upper teeth on the natural dentition? That's what I'm looking for. I don't want to grind this so tight and so knuckle tight that the food just gets pushed away. It needs to stick on there. It needs to stay on the table to get crushed. Our natural teeth are crushing teeth. Working and balancing occlusion is more of a milling because it has to go side to side. Okay? So I'm trying to facilitate that crushing motion. The other consideration that we have to maintain is direction of force. So it's easy on these demo teeth because the lower faces up. I put the cusp in, but remember, the force is all going up and onto the upper ridge. But now if I start having to tilt teeth, or if the teeth are, remember I showed you that lower teeth are tipped, now all of a sudden direction of force is going away from the crest of the ridge. Careful. So I have some samples to show you of that as well, of how I deal where the lower tooth is shaped like this. We have to be careful because remember, that upper has to go this way, not this way, because we were taught in school that I take that tooth and I set the upper like this. Then the direction of force is going to go this way, yet the crest of the ridge is up here. And that's why we break things. And that's why the denture breaks. So then I have to try to finesse the tooth a little bit to make sure that the force goes upwards. I will show. So on this first example, so that's what I do, is I go in and I find the fossa points. Then I take the tooth and I color it, and then I'm custom grinding it in, and then I can go in and I can maintain position. I maintain the overlap that's here so that it's the shearing cusp. It's not locked together so that the food is somewhere to stay and get crushed, yet it still has that degree of freedom and wiggle so that I have freedom in there, yet to follow within the chewing cycle of the patient. So this is the last motion I check, is you can see how I just moved the articulator. I facilitated a chew cycle. I didn't take this and do what we typically do, where we move the articulator on a regular articulator movement. You notice how I did not do that? What did I do automatically is I've learned to take the articulator and facilitate a chew cycle. So now I'm imagining that person, whether it's more horizontal or whether it would be more vertical. And what I'm doing now is I'm following that, and then I'm looking for the marks within the fossa. See? There we go. And I'm looking to see where the marks are within the fossa area of that tooth to facilitate that. That's how we're going to get rid of the stresses. That's how we're going to get rid of and deal with directional force. That's how we're going to, again, help with the fit of the denture in regards to it not tipping and the patient complaining of ill fit. Okay, so that's situation number one. Okay, situation number two, I'm going to change out the teeth. Bear with me, and we're going to find this. So, sorry, different lower model, which I'll now show you. Let me just see if that helps. Yeah. There we go. There, look at that. Huh? Yeah. That's what you can see, a lot flatter. So let's deal with this side. So we've got this super wide, and actually you can't quite tell, but it is leaning a little bit. Okay, so it's super wide and it is leaning a little buccally. So this will work well for us. So again, my center point is about here, where I'm going to say that's the contour of the fossa as best as I can get it. Now, typically what we're going to do is we're going to go to our tooth drawer, and I'm going to find a very flat tooth. So, for example, what we typically would see is I would take a tooth with very worn down cusps, and that's what I would be doing to go in there and grind in. Okay, that's typically how we're taught and how we'd handle the case. The problem with these flatter teeth is you can see that the buccals are also very worn flat. And you have to keep in mind, coming back here, the tooth is really wide, but what's back here are the pterygoid muscles, so the medial lateral pterygoid, and we get really tight back here. And so a lot of times what we're going to have is a lot of cheek biting and issues going on there. I want you to recall and remember that most of the chewing is done on the sixes, so on the molars, pardon me. So here on the first molar, most of the chewing is done on the first molar. So when it comes to the second molar, I can still go in and use a lingual form. So I'm still going to come in with a very cusped tooth, and I'm going to be shooting for here. But you're going to say, geez, Mark, that's not good. That's not good contact. What are you trying to do? Okay, so again, remember, I'm going to grind the cusp in, and I'm going to grind it in. But what I'm looking for is to have this overlap. I want this buccal overlap still to be maintained, and that's why I'm using a cusped tooth, so I can still keep the buccal cusps there because they were there to begin with. If I go right to a flatter tooth, the buccal cusps have already been sheared off for me. I don't want that. Why do I want the buccal? Well, remember, I want the overhang. What's the overhang going to do? Well, the overhang helps keep the food on the table to get crushed. That's job one. The second thing is that the buccal cusps are going to be there to keep those pterygoid muscles, those cheek muscles out of the way, so we're not cheek biting. So that's why I rethought this. I said to myself, honestly, you guys, I said, is this it? Is this what I have? I've left school. I'm in private practice, and these situations are arising, and or the center here, such as it is. So I'm going to come in and I'm going to try to shoot for it, get it into position. So I'm not going to pay too much at the moment to where I am on the ridge because this is just a demo case, but it's to show you how I'm approaching this. Okay, I hit that. So now what I would do is now I can start to flatten this cusp tip because it needs to work within this type of a situation. So I can take that cusp tip and I'm going to flatten it. And that's going to bring the whole tooth down into contact. Yet it's going to leave me with that buccal overhang that I'm looking for. Something like this. So you see now how that tooth is starting to come in. I just don't have that cusp tip sitting there, and so now it's flattened, and I can again take my red pen and I can come in and tap it into centric a little bit. And then I'm able to see my contact points now that are showing up. Very finite work. And now from there, I'm also left, and I'm going to mark it in green for us, the overhang. So that overhang right there, which is very important because that's what keeps the food on the food table. So let me try to angulate it so you can see it. Let me go this way. So now that's how it's going to look in centric. So you got to love the central nervous system, right? I'm holding an articulator. I'm looking at my computer screen to make sure I'm having to hit the focus button as we go through this. So I ask you, this is why I'll be happy when we can do this in person again, so I can really show it to you. But remember now, I'm going to go through that motion of a chew cycle. And then I'm looking to see the contacts. And you can see there's a little bit of hit here on the guiding plane right there. Okay, look, there's a little hit up here on that guiding plane. So what that's telling me then is I can still there and maintain. So I've got a centric contact, but now I'm going in and I can watch for my excursions so that I'm not hitting the hit and slide, because remember, I don't want the hit and slide. And remember, I want that degree of freedom. So I want to maintain that freedom, but I also want the buccal overlap. Sorry. I want to maintain that buccal overlap to allow for the food to get held into position. So this is why knuckle tight occlusion doesn't work. It can't be knuckle tight because the food gets squished out. It's not holding the food down properly. So we can explore that. And that's how I manage these types of situations from that. So I am now looking for our next model. And you know what I'm going to do, everyone? Let me just have some fun here. I'm going to do some contouring. So I have a model here again. But what I'm going to do is I'm going to facilitate in a crude manner, but I've just ground that tooth flat. So I've put a negative curve on this first molar, okay? So it's a negative curve. So I want to demonstrate how do I approach that when I see those types of teeth posteriorly. Now I'm picking on the molars because it's just the easiest demonstration tooth to use here in a webinar because it's you can see it, but this applies to each and every tooth as I move forward. I try to, again, find the best part of the lower fossa or where I want to position that cusp. Then I start to bring the cusp into play. I grind the cusp in, then I check the guiding planes and recontour the cusp to maintain that freedom. So I've got the freedom movement, and then I can go in from there and I carry on and check for excursions, especially regarding the chew cycles and such on that situation. So I'm going to pick a different tooth here. So one moment. Here we go. So again, I'm going to use a cusp tooth. So I'm going to come in with a linguiform. So again, a cusp tooth on an implined, worn down dentition that I've just facilitated myself, but there really no, okay, it's very worn flat. So again, how do we deal with these types of situations? By not tipping the tooth in there right away in the same manner. So that's the trick. So I'm still going to maintain a buccal overlap if I can, and I'm still going to maintain a cusp contact. So I'll draw that out for you. So the tooth is shaped something like this. And I'm going to come in here and I'm still going to try to maintain, but now I'm going to grind that cusp tip, and then I'm still going to have that buccal overlap. But what I'm trying to do is I'm trying to not tip that whole tooth down, because then that shifts that directional force this way. I'm trying to still keep the tooth up. So I'm going to be grinding on this area so that I can take the tooth and do this to it, so that that directional force goes more up here into the ridge area of the denture. So then thus controlling the directional force and the stresses that are on the denture. And then that cusp will be able to facilitate in here. I appreciate it's not ideal. I appreciate that, again, I might have some, we're going to have a difficulty with the working and balancing situation, especially because of this. I'm not looking for working and balancing anymore. I'm looking for the centric contact, directional force, and I'm looking to make sure that I have a chew surface here following that chew cycle of the patient. So remember, that's a teardrop motion. I can find other teeth to have working and bouncing contact on. If I can't hit it with every tooth, I'm okay with that. So that's, I have to overlook those things, and that's fine now. So allow me to reposition myself and go in. I'm going to heat the wax, and then I'm going to line this up. So I want you to remember, number one, patient has a chew cycle. Whether you can discern it or not, they've got one. Number two, I want to maintain as much as I can some buccal overlap on the situation to help hold the food on the food table. Okay. Okay, so there's a rough initial positioning of that molar on that area. So let me get focused and holding here. Okay, so if I swing it around, you can really see, like it's looks terrible. Yes, it does. But now remember, I'm going to color this. And I'm going to bring it into occlusion. And I'm going to start my initial little taps. And I'm going to open, and you're going to see where it's hitting. Okay. So you can start to see the little red dots and where they appear, okay? And I appreciate that that's not ideal at the moment. So again, I need to heat up some more wax and make a little bit of a bigger shelf here for the demonstration. So thank you for your patience. There we go. So again, just for demonstration purposes, just to show, look, that doesn't fit where the darn right now, but now I tap in and now you can see the red dots. So I'm squared up in the middle of the tooth, even though it's on the incline. Okay, I'm in the middle, so that's good. So now I'm going to take that tooth and I'm going to start to grind it. So forgive me. Here comes the noise. And I'm going to flatten it out. And I also know that I have to go on a little bit of an angulation, but I'm leaving the buckle. Remember, the teeth are acrylic glass. They're self-polishing. And now I'm coming in and I can do this, and you can already start to see I'm closing the gap up. So you can see how things are starting to kind of come together a little bit better. But yet I'm left with this, and this is important. I'm left with a little bit of gapping to help hold the food and to shear the food there. It's also keeping the cheek out of the way, okay? And any cheek biting that can develop in these situations. If I just standard go in right away and do what school taught me, which is if the lower is shaped like this, you put the upper like that. You put the upper like that right away too. That's wrong. Please stop doing that. That's what's creating all of our grief. It's taken me, as I said, 15 to 20 years of banging my head on the wall initially as I left school. So I'm going to color it again. Then I'm going to come in, again, tap for centric. You can see how I'm seeing now the tap marks on the model here on the lower. And I'm going to do some more grinding because I can also see the marks on the teeth as required. So it's super accurate, and it's not giving me the erroneous readings of what articulating paper does. Again, I'm going to contour. And I'm going to close in just to show you kind of where we're at. And you can see, whoa, that's not supposed to come off. There we go. And now you can start to see how it's really closing in. And that's good. That's what I want. But I'm also not looking for it to be knuckle tight, because now again, we've established knuckle tight is not good. And I'm having overlap, which is good. See the overlap? There we go. See the overlap? So I want the overlap to help hold the food on, because remember the video? So I want that overlap there. It helps hold the food on. It's helping keep the cheek out for cheek biting. Get my contact points. So I'm really grinding the lingual flat. Yes, this is very becoming, whoops, let's hit focus again. It's becoming very flat. That's fine. Because again, the lower's flat. So I'm coming in there and again, reestablishing my dots and where the contact points are. And then again, I can start to facilitate and open up on my articulator and facilitate the freedom movements. So from here, then I can start to facilitate my freedom movements. And when I do that, you're going to see that there's a hit right away right there. That's new. That's a new mark. Because the tooth is tipped, it's going to hit on that end. So I'm going to be looking more on this end of the denture tooth for that very reason. I'll be seeing those types of marks over here more, because then I have to recontour that on the tooth as well without changing the centric position. And that again is the beauty of using the red pen technique and coloring it versus articulating paper. You'll become proficient at this. I'm showing you, so it takes a while. Once you become proficient at it, it goes quickly. So instead of using just a big burr and boring it out, I mean, the idea behind this is the patient needs to eat, it needs to function, we need to control the directional force, we need to give that patient the chew cycle, we need to keep that overlap to hold the food on, regardless of the shape of the lower, and now I need the freedom movement, and I need a chew cycle movement. And that's how I facilitate this, everyone. So I can go in and facilitate the chew cycle movement. And then again, I'm coming back to look at the markings that are left on the tooth here, as well as verify against the markings that are left here on the lower tooth. And that's how I can facilitate how to do that on a negative arched or negatively inclined tooth. Is it perfect? Well, I don't believe in perfection because that's hard to achieve, but I believe that we're able to find a good centric contact, maintaining the principles of the freedom concept, which is freedom and occlusion, which means I have their buccal overlap. I'm trying to keep food on this food table to get chewed, but as well have the food stick up here and not grind everything flat. So there's still contour here to grab the food and stick the food to hold up here to keep getting smashed by the lower. And that's how we facilitate, and then keeping a positive tooth, again, the positive directional force contact. Those are important situations for us when we deal with lower natural dentition. Okay. Next, quickly talk about anterior teeth before I forget. Back the camera off a little bit. Refocus. Okay. Certain models, everybody. I need a little bit of a better demo guide to show you here. Okay. Overbite and overjet on natural dentition. Okay, so I like the VITA Excel. Why do I like VITA Excel anteriors? Is because the incisal edge of this tooth is thicker than other teeth. So it's CAD-CAM designed to be thicker. So the incisal edge is thicker. This I like, because again, we're dealing against enamel, and I don't want to damage the enamel. I want the enamel to win in a contest. I'd rather the tooth break than the enamel breaks, but it's got a thicker incisal edge to it. The idea behind setting anterior teeth is we're always governed by the midline of it, but we're also governed by, well, how much overbite and overjet do we need? That sometimes is given to us by the dentist in a wax rim or a planed rim. what I want to remind you is you have to think back to the videos that we showed to show that movement. If I can determine how that lower jaw moves and that patient's bite cycle, then I'm able to position the teeth accordingly. Remember on that case, I had an extreme amount of overbite and overjet, where the textbook would tell me that I'm out to lunch. Yet I've challenged the textbook, let go of my belief system, and said, how do I make this work for the individual? And I can, because that individual works within a certain chew cycle, a certain bite pattern, and that works for that individual. So you got to get out of your own way, everyone. We already set teeth and we already have ideas of how to set teeth, and I'm coming today and I'm challenging you to think differently. And that's hard. Change is hard. And it's hard because we fall into our pattern right away. The patient has a pattern and a chew pattern. Well, we have a pattern of how we approach a case and set a case up. So what I want to do is I want to take this and I want to set it where it needs to go. So for example, if it's a 1-to-1 or 2-to-2 relationship, because that's where it just needs to go, fine, so be it. But I want you to remember that when that patient moves and that jaw moves, remember the videos, they're going to posture forward. They're going to move forward to some degree. How much? Typically, you're going to see a patient move anteriorly about 1 to 2 millimeters. That would be a fair market value assessment of how it works, okay? Give or take. I typically see that jaw fluctuate anywhere into that 1 to 2 millimeter range. And that's a realistic number. And sometimes, as I said, it swings out to the left or to the right. And those little nuances, I have to grind then into the backs of the linguals of the upper anteriors. But typically, I'm looking to, again, when I set, I have to watch how I space it out. What's going to work for that individual case? That's fine. So don't pay attention to where I'm setting this on the models as the demo. But I'm looking to show you where do I set it. And then I need some sort of a gap here. Whoops, let's find the camera, Mark. There we go. Get out of the light. I'm trying to find that gap. And then remember that that patient is going to posture forward somewhere into that 1 to 2 millimeter range. So they're going to posture forward about 1 to 2 millimeters, give or take. So don't look at the lower, don't look at this. We're going to look right here. And I'm going to, again, not only my center contact, but now I'm going anterior posterior. So I'm moving the articulator. And that's when I can also then take and I can either coat the bottom teeth with the ink or the upper teeth with the ink. Either or works. I like to usually do the denture teeth. And then I can go in and I can see then the specific black marks that are presided then on the lower. Okay, so switching out models again, going somewhere different. And then with the anterior posterior movement, okay, of it going anterior posterior. Sorry, it's hard to hold this. So you can see I'm going anterior posterior, and then if there's ever any contact, it's going to mark up in here in black. So what I'm trying to do is facilitate the movement of the jaw in relation to the anterior teeth so as to, again, I appreciate that there's a position that they need to go in and a length that they need to go in, but I'm trying to determine what the correct overbite and overjet is and allowing a little bit of freedom of movement in there to allow for that. To allow for this, to allow for this. Now, remember the articulator set at a 30, so it's sliding this way typically. So again, we can watch for that. So how do I check that in the mouth? I have the privilege of, again, doing wax try-ins and seeing the patient directly. So I'm going to take a Q-tip. You can't use an indelible pen in the mouth, so you can't use these in the mouth because the color will bleed away. So I take a Q-tip and I coat it in petroleum jelly or Vaseline, and then I rub that onto the articulating paper, and I impregnate the cotton swab with the color, and then I can go and I can do that to the tooth, and I can color the incisal ledge. So again, it's not pretty, but I can show you that I can color that, and then that goes in the mouth and the patient talks, and then if I see a mark line, it'll start to mark it, and you can see there'll be this little line right there. Remember, get them to say the days of the week, the months of the year, and then I see that little line, and then I can take a little burr and clear that out of there. That's going to help prevent the chipping. So as a dental technician, the difficulty is I don't see the patient. It's hard to tell. I have no information from the doctor. And then you got to hedge your bets, everybody. So I'd rather go in there, and you know that in situations like this, when you see a tooth like this, it's ahead. Look how far ahead it is. Yet we have to bring all of the natural dentition around. So you're going to have this big gap here in terms of your overbite and overjet, but very little space here. So yes, you're going to have to come in here and most likely grind the lingual away slightly to accommodate this tooth. But you also can see that this tooth has a wear pattern to it. So you also can look and see that it's got you can see the wear pattern. It's not straight, it's got a wear pattern. So that other denture or the opposing natural dentition, if it's a partial, something's abraded that tooth down over the years. So we can go in and you can identify those spots. So what I wanted to do today was to show you, number one, we have freedom and centric. And freedom is good. Number two, we have wiggle. Okay, so everyone, I want you to start doing the Wagenseil wiggle. and watch everyone stare at you. So you're doing the Wagenseil wiggle. Patient has a chew cycle. So there's a specific chew cycle associated. And now when we're doing natural dentition, what do? I identify the target point of where I want to put the cusp. So regardless of the tooth, regardless of the situation, I'm looking to target where do I want to target that cusp on that lower natural dentition. And then I color the tooth. I take the tooth and I color it in usually red, because red for me is the cutter. So again, I want to color that and then place that in and watch the marks. And then it's going to mark it out for me. And then I slowly grind the cusp, and I'm slowly grinding this lingual cusp thinner, so thinner, to make it a little thinner to fit into that lower bowl that I have to go in there and then give me that degree of freedom and then function within the chew cycle, maintaining directional force up. And that's how I strategically go in and do that. And especially on these situations where I have a negative curve on a tooth, I again want to keep the overlap. I want to keep this overlap as much as possible. Flip this. I want to keep that as much as possible to again help the food stay up and on the teeth versus getting out. So it's a much different approach than the knuckle tight that I was taught in school, and making that lower tooth and the upper tooth fit at all costs, meaning that I grind that upper tooth so it's like a pancake against the lower, regardless of the contour of the lower. It's incorrect. I need some gapping. I want to maintain gapping. So I've rethought the process. You guys, I'm 51 years old. What? Yeah, I'm 51. I started when I was 17. It's been 34 years of my life now building dentures. I love what I do. It's the right path for me. And I love our professions of dental technician and dental denturists. I love making dentures. But again, I admit the first 10 to 15 years was wrought with frustration, and I realized this is what I have to look forward to. And I've rethought the process. I had to get out of my way, and I wanted to share that with you today about getting out of your way and rethinking how you do this. Lower models are all over the place. You have situations like this where there's steps, and again, there's no right or wrong answer of how you approach these situations. You have to make calculated decisions, but I will always fall in to say, I'm trying to, again, get that cusp into that fossa. And sometimes it's better to do this and ride it versus bringing that tooth down, because I have a directional force issue. And now what's the posture of the jaw when that patient moves? Sometimes it's better to do this, okay? And again, instead of coming up and locking it into play, I want to rotate up and I want to come this way more, because remember, there's a chew cycle associated with these things. And if I can identify that chew cycle, even if I can't, I want to, again, always err on the side of caution. So these are tough decisions. It's nice to have another denture to look at and what the new denture is replacing. That gives me some idea. But I've gone through where I've only contacted up at the top, and here, say with a molar, and then I can come in with a second, and maybe, again, I want an upright contact position. I don't want to tip things. I want to always directional force up. So these are things that I wanted to share with you today. I'm going to call upon Jim to sneak back into the conversation. Hi, Jim.
Hi, Mark.
Hi. Okay.
Very good. Excellent.
Do we have any questions?
We do. We do have some questions. So let me go through a few things.
Thank you, because I don't see those questions up. I'll just leave the camera on. So thanks for typing in, everybody. Again, the key points here are freedom, watching the directional force of the tooth, remember the freedom, remember that you don't want to lock it in, so I have to grind that cusp a little narrower to make it fit against that lower, make sure that there's the overhang to hold all the food in. So I wanted to show you those videos first, because that's really helpful to show how the system works. And again, I had to rethink this. How I build an upper denture now is dramatically different than how I was taught in school. But I've also reduced the errors, I've reduced the breakages, I've reduced the tooth chipping and all the issues associated with it, because now I started to pay attention to how it functions and how the denture integrates into the body. And that's how I wanted to, again, share. What I wanted to do was to share with you today the rethink. It's going to take you some time to rethink this, and you can watch the video over and over again now on YouTube, because it'll be posted, to again rethink how you approach the case and be surgical on how you do it and how you anchor the tooth in, versus just taking teeth and going and grinding them in right away and getting them to fit on here right away. Be strategic, because guess what? The case is coming back to you anyway then if it's wrong. Is it not? The patient's coming back anyway. Spend the time on the front end. Really pay attention to how you do it. You're going to save yourself the problem after. The nice thing about using the VITA teeth is that they're acrylic glass. I don't have to worry about the polishing after. They're acrylic glass, so it's going to wear well against the enamel. And they're designed with those cusps and the overhangs. Everything's already built in. I'm just modifying it to the lower natural dentition. I'm using product that's adaptable and helps me be that superhero for that patient. Okay, Jim, questions?
All right. Yeah, Mark. So for the audience, remember that, as Mark mentioned, the webinar has been recorded. You can find it on our VITA North America YouTube channel. You can follow us on the various social media as well and find it. So please visit us again and look at all of Mark's webinars. We've also done it with Class 1, Class 2, Class 3, and now a combination syndrome. So there's all sorts of different topics that you can look to our website and revisit with Marc. The CE, if you are interested in CE, you should get a follow-up email from us, from the marketing, that will ask you a few questions, get your information as far as your MBC credits and so forth, so that we can provide that and get you some CE as well. These are the social media: Instagram, Facebook, LinkedIn, and of course that North America YouTube channel. If you want to get a hold of anyone here at our office on the help desk, this is our information for the help desk US. We do talk to and work with all the Canadians as well, so please get a hold of us if you need to. This is a list of all of your reps. If you need to get a hold of your local rep to talk to them, discuss with them about any of the topics, any about the teeth, the VITA Denture teeth, please do so. Again, we serve both the US and Canada. And again, for Marc, today was July 13th webinar. We've got several more the remaining of this year. We have August 10th, 16th, 5th, 23rd, 16th. And maybe we'll add some more depending on your comments on what you're looking for. So please email us if you'd like to give us some feedback on what exactly you'd like to see from Marc in the future, or from any other instructor as well. If you need to get a hold of Marc, this is Marc's information. Yes. Marc is gracious enough to help you as a customer follow up with any questions you may have about any of his topics. So this is Marc's information.
Please contact
that you can see here.
I'm here to support
which is very nice.
I'm here to support you. Thank you. Sorry for interrupting, Jim. And I want to support
you.
And
if you're German speaking, you can call and talk to Marc in German as well.
Yeah.
And Marc, if you'd like to, if you want to face the camera.
There
you go. Yep, that one. Excellent. So, yeah, speak a little in German.
Oh, okay. Let me switch cameras. Okay. Let me close this one out then.
I can see you now, so. Yep. Are you there?
Oh, yay. So I'm here to support you, and I want to support you, and I'm here to help. So you can contact me directly via that email, or you can text me. You also can follow me on social media. So I have my own Facebook page and Instagram page. So please, you can like me and follow me, and then you can contact and message me there as well. I'm here to support you guys. I'm here to lift a profession and to help move them forward, and to help all of us that are in the trenches day in and day out dealing with this. I want to thank you very much for hearing me and allowing me to, into your day to help stimulate you and get you to think a little bit. As I said, I really broke the mold open today a little bit in terms of how I approach things. It's quite different than what we've been taught, and it's very surgical and very specific to the patient of why I do it. And I wanted to, again, explain and be clear of why. And now I'm banging my head against the wall a lot less, and I'm a lot happier in my profession, and I have a lot less issues. And it's been a tremendous strength for me to give me the courage to move forward every day, to be that superhero for that patient, knowing that I can handle these different types of cases. So remember, there's a chew cycle. Remember that the patient has that chew cycle. They have that pattern. There'll be that movement. It's usually 1 to 2 millimeters. Remember, they need freedom, and they need that freedom to move. Incorporate that into the denture, on the single denture, and watch your stress level come down and the acceptance go up. It's been phenomenal. So we're here to support you. We thank you for taking time. We are here to support you, and we ask for your business. Please try the teeth. We're here to support you. And in the future, we can do in-person courses. And I would love to just do a single denture course one day with VITA. So you'll get an email from VITA in the next day or so regarding this webinar. Please, it says if you have any feedback, please fill it out and send feedback back to the company. They do read it, and I do hear about it. So thank you for that. Give us feedback on the course. Let them know if you were happy or not, or areas of improvement. But again, what we can do once fully restrictions are lifted and the hands-on courses that we can do so that we can support you even more. Because again,
thank you, Marc.
Some patient somewhere wants us to be their superhero.
Excellent said. So, Marc, one of the questions is if the patient has opposing occlusal amalgam fillings, how do you treat that? Do you grind into the filling? Do you work with just do it all on your denture teeth?
Yeah, so I'm gonna. Yeah, so it's going to be very similar. I mean, a lot of these models that I use today, some of these were crowns. There was a lot with fillings in them, and etc. So I'm trying to again find I'm trying to find the best point of where I want to drop that upper lingual cusp into. I'm trying to find that spot and then work in that spot. So whether that's over a filling or not, unless I've been told by the doctor that that filling is suspect, but then why am I building on a suspect filling? It should be repaired. But that's where I'm trying to drop it in. So I'm dropping it in, whether it's a crown, whether it's a natural tooth, a braided, or whether it's filled, anything. The principle remains the same, is I'm trying to find the best part of that lower bowl to put the upper into it and then grind the upper specifically contoured into that. So I hope that answers your question. For me, it's irrelevant what the surface is made out of. And just in terms of the best location for me to put the cusp into and then have it operate and function in that zone.
All right. So another question, what would happen if the process of grinding the cusp inclines of the upper functional cusp while ensuring centric contact, resulting in an increased area of freedom? So I think they are asking, you know, if you remove that functional cusp, that incline, what about the freedom? Does it change it?
So it does. I'm trying to increase it. So I'm trying to, on average, give about generally a 1 to 2 millimeters of wiggle room, of freedom, to again allow a bigger bullseye for them to land into centric in. I don't want it so specific that they have to hit it dead center every time, because again, that's not realistic. Yet that's what we've been doing all these years, you guys, is expecting people to be able to land into centric accurately and perfectly every time. That doesn't happen. And so that, again, we have to put that freedom in. So with that said, the older the patient, the more degradation of that patient, meaning that if I know that their muscle tones and things are starting to again degrade, if I know there's a lot of wear pattern and they chew more horizontally, I'm going to increase the freedom, which means I'm taking that cusp, yes, and I'm grinding it a little thinner. So now my choice to begin with makes important sense to me regarding the size of that lingual form tooth that I'm using and customizing. So I'm using typically a larger tooth that I have the ability to grind away from, yet still maintaining the cusp integrity so that there's still a cusp size, but I'm still trying to, again, keep that freedom movement. So the freedom will increase as I'm grinding the guiding planes thinner. Yes, and typically that's okay. I'd always err on the side of caution of more freedom's better than less freedom. I found that now consistently over the years as I look over to my treatment room, consistently over the years, more freedom's better than less, because then I have more wiggle room. I have more flexibility in the situation and in the denture. That's better than less. I'd rather have more than less, always. I hope that answers your question.
All right. So how would you, in the combination syndrome, how would you handle a crossbite?
Oh, okay. Same situation. But, okay, that's a whole other course, Jim. Yeah, we just now have another course idea. Thank you, my dear colleague, for writing that in. Okay, so in a nutshell, let me grab a lingual form tooth and hold up a model. You know, again, this is terrible to show you. So again, now I'm just cross biting it. As I bring it up there, I'm cross biting it. So now again, I'm just now taking the buccal cusp. So instead of the lingual cusp against the lower natural dentition, it's the buccal cusp that comes into the fossa of the lower natural dentition. And now I'm just having to grind the buccal cusp to keep the freedom. And then I got to watch the guiding plane of the lingual cusp just so that everything functions together. So it's similar principles, just reversed to a different cusp. So again, I spent a lot of time talking about sort of the upper lingual cusps, because that's typically where we're going to go. But if you have to put a buccal one in, or again, it doesn't matter what cusp goes into that lower bowl, so long as it has that freedom and function within that cycle. So from a crossbite perspective, it's just now sticking the buccal in. Now a buccal cusp is a little thinner than the lingual, so typically I already have a little bit more room incorporated into it. So although there's already less grinding involved because the cusp is a little thinner, I just have to watch that lingual cusp because it was sort of the main chew cusp. So I just have to watch the guiding planes on that. In a nutshell.
All right. Yeah, we'll do that as a course. It's good.
Thank you.
Someone was asking whether or not you've used the tech scan digital occlusal analysis
yes,
equipment.
T-scan. Yeah, guess what's getting incorporated to my future freedom courses. So that's something that we're.
And so you would recommend it.
I would. Everything that I've been teaching up to this date has been the manual way. So the manual way meaning articulating paper in terms of not articulating paper in the mouth, but coloring the teeth and such and so forth. And the T-scan is really nice now because it is the digital version of it as we move forward. So that's something that's coming for us and for me too as a trainer, adapting into that technology and digitally as well as we move forward with digital dentures. So it's coming. Yes, but I recommend it. It's pretty cool stuff.
All right. Now that we know that you don't use articulating paper, but if you did use articulating paper, what thickness would you use?
The thinnest you can find, or the silk, even better. The thinnest you can find, or silk. So I'm saying like 80 microns or thinner. And the only ones that I know 80 is about the thinnest I've seen. Hey, Jim. Or the silk paper, and I know Candular makes the kind of the silk. I call it silk, but that real thin, clothy type of material. Yeah. If you're going to go there, that's got to be super thin, everybody, because it bends. And I just got so frustrated because it was like, well, where's the contact? And then you're over grinding things and you're ruining it. So that's why I've gone to this very surgical, precise type of approach, and it's worked well for me. But I've settled how many years has it taken me to get to today, 34 years of trial and error to get to where I am today. But thin.
Now that you know what you know, is there a good book you can recommend to the audience that gives a good review?
No, because I haven't written it yet. Jokes aside, I'd have to go back into my catalog of books. There are books out there that that you can read, but there's really nothing about the freedom concept and that. I try to stick to books more about how the muscles work, how the masseter, how you chew. Anything chew cycle related would be good, but I can't specifically guide you into one book or another. With my apologies, because again, I think you have to appreciate my combination of getting me here today has been my experience, my journey, but me reading different varied books through my career that I've just brought together. So my advice to you is start reading different concepts and different ideas. And that's been beneficial to me.
All right. How often do you use lingualized occlusion as opposed to bilateral balance setup?
So almost 99.9% of what I do is lingualized in concept theory, modified to the situation. So again, an upper denture today is a form of lingualized occlusion, but I'm not having lot of buccal contact. I'm going to say 99.9% of what I do on all situations is a modified lingual occlusion concept, modified to that patient's specific needs and ideas of what we need to do for that person, but always sticking to the hardcore principle of the lingual cusp has to go into the lower fossa. The lower brings the food up to the lingual to get smashed. That's the concept. And it follows a certain chew cycle and pattern. You can, and again, when I say it's a modified lingualized occlusion, right away people just think the only thing contacting is the lingual cusp. No, you can have buccal overlap and you can even have light buccal contact. It's still a form of lingualized occlusion. I'm just keeping the freedom. I'm making sure that we have that freedom motion to that, number one, freedom, and number two, that chew cycle. And I'm again, my dear colleagues, where I am now, I have far less troubles and stresses in my life than I did when I started, but I changed what I did. And that's what I'm sharing with you today. I again hold the articulator different. I manipulate the articulator different. And I showed you that. I just don't do those standard articulator movements anymore. I'm trying to facilitate the chew cycle. Those types of little tips have really benefited me. But man, I had to tell you, I had to get out of my way. And I had to let go of what I thought was right. And then I'm building dentures with 5 and 6 millimeter overbites and overjets. And I'm breaking all the rules that things shouldn't work, but they're working, which tells me I'm on the right path. And that's why I'm telling you, you can challenge yourself. But all of this is the lingualized occlusion concept of a form, yes.
All right, I can help answer this other question. It was asked, well, your glass acrylic that you were talking about, what tooth lines is that? That's all of the VITA's premium tooth line, midline teeth, you know, the VITA Pan, the VITA Pan Excel, the PhysioDents, and so forth. Those are all made out of a material that has a glass matrix embedded into it. Next question could be...
everything but MFT. MFT is just acrylic.
Right.
All the other tooth lines are acrylic glass. And then again, I showed you today, I use lingoform, and then I modify the lingoform because I want that cusp overlap to help hold everything. Remember, I showed you I brought along some Sinaioform, which are the real worn down, abraded teeth, much like a 10-degree tooth. I don't use these, even though they're acrylic.
All right. Mark, how can we resolve cheek biting?
Yeah. So again, that has to do with using the lingoform, the overlap, okay, and watching again where I'm positioning, and if I can see the patient, then I can see the thickness of what's going on, how thick the muscles are, how thick the pterygoid muscles are, whether or not they have that line on their cheek, the linea, what's that called? I can never remember that darn name. Linea something. There's that cheek line. Now watch, everyone's going to type it in the message box for me, please. So again, it's not going knuckle tight. Don't go knuckle tight. Leave it open and try to leave that overlap so that that upper buccal overlaps the lower, and you've got that overlap. That's important. And you can only do that because the lingoform are designed like that. That's why I use them. Linea albicans?
Linea albia.
Linea alba.
Linea alba.
Woohoo! Thank you. Thank you.
So the last question. Last question. More Marc Wagenseil wiggle. It also means less centric contact? Question mark.
No. No, because remember, I'm leaving the center. So the contact, theoretically, the contact point of the cusp is in the fossa. And as I'm grinding the guiding planes, so I'm not at the very tip of where it's touching, the guiding planes more down the plane itself is where you're touching and allowing that freedom there. So you're not necessarily thinning out the very cusp tip as you are more of the body. That's where you make that alteration, okay?
All right.
Yeah.
Marc, any parting words to our group? It was an exceptional webinar as always.
Freedom is good. Lingual exclusion. So that form modified now into upper natural. Remember, there's a true cycle, days of the week, months of the year to identify it. You can mark it if you want at first to help yourself identify it. Remember, I now use the pens and mark everything. I don't use articulating paper per se because of the deflection marks. Remember the chew cycle, and remember the patient has that pattern. And remember, more freedom is better than less. Remember the buccal overlap now, specifically to a single denture. You want to keep the food on the lower teeth so the upper helps hold it in. Because remember, the lower is bringing it up to the upper to get smashed. That's the idea behind it. So again, thank you for being a superhero. Woot, woot. We don't testing in yourself. Thank you for allowing me to challenge you. I, again, challenge the system and a lot of what we were taught and believed to be correct. And now I'm doing things that are so far away from what I was taught originally in school. And that's okay. That's how we push it forward, everyone. That's how we be superheroes. You push it. And thank you for allowing me to give you that nudge too and hearing me out. Thanks to VITA North America for their support and continued support of our professions and their educational programs. So thank you for funding that still and being here to support us, and for you for investing in your time, everyone, to again, grow. So thank you.
Thank you, Marc. And for everyone, we've got Marc with several other webinars coming up in the future. The dates are on your screen. Please join us if you can. If not, then like we mentioned, they're going to be posted. All these webinars are recorded and posted on our VITA North America YouTube channel. I want to thank everyone for joining us again today for the VITA Learning webinar with Marc Wagenseil. Marc, thank you very much again. And this will now conclude today's webinar. Thank you, everyone.
Have a great time, great day. Thank you for your time.